Hello, welcome to our first conversation on the state of healthcare in the United States. I'm Susan Bornstein.
Hi, and I'm Jeff Zakem, and today we're going to talk a little bit about cost in the U.S. healthcare system. But first, a little bit about us. Susan and I met as part of a Master's in Public Health and Health Services Administration program at the University of Michigan. Susan, you've spent more than 25 years as a practicing gynecologist. Tell us why you shifted your career.
Well, I was in solo private practice for a really long time, which I enjoyed. My patients appreciated the fact that when they called, my staff actually answered the phone, no voicemail. We knew who they were, and they received personal attention from all of us in the office. Over time, rising overhead costs and my inability to negotiate with insurance companies forced me to accept the new financial reality, and I went to work for a large healthcare organization. My patients weren't thrilled with the corporatization of the practice, but were ultimately pretty accommodating. For me, the loss of autonomy was balanced out by being able to relinquish a lot of the management responsibilities. Unfortunately, the time I recouped, which should have been devoted to patient care, wound up getting usurped by the demands of the electronic medical health record, and we'll talk more about that at a later date. Things went okay for a couple of years. The real catalyst for my change in career focus was frustration over the increasing challenges my patients were facing with costs and accessibility of healthcare. One example in particular stands out. I had a patient who was in her 40s, the mother of 3 adult children, who was living in severe poverty while going to school to further her education to improve her economic circumstances. And she was finally able to get health insurance under Kentucky's Medicaid expansion under the Affordable Care Act. Once she was finally treated for her significant gynecologic problem, her quality of life improved. She finished her education, and she's since gone on to work in a social services organization giving back to the community. Patients like this would suffer if the Affordable Care Act was abolished. I simply couldn't stand it. I went back to school for a master's in public health so that I could more effectively advocate for health system reform. The current system is just a little bit broken. Jeff, why did you pursue a master's in health systems administration?
Yeah, well, thank you for sharing that patient story. That's so compelling. For 15 years, I have been working with a health system, developing education, everything from regulatory and compliance training to training on our electronic health record. And it really has been eye-opening seeing the complexities of the healthcare system. When I started my current job, I wasn't planning on sticking in healthcare for the long term. And frankly, now I can't see myself working in another industry. The organization that I work for, they provide excellent quality care. And still, there are so many challenges and opportunities that we face on a daily basis. I believe that my background in how people learn, how people apply that information, how people are motivated, and how we as organizations can help people make the right choice easier. I believe that that's powerful information that healthcare organizations can use, and I can use to help healthcare organizations be better. And not just from the point of view of the organization, but really more importantly from the point of view of the patient. And beyond the walls of the healthcare system itself, it's becoming a much bigger factor in the health of the population, how these organizations interact with the community. We think about things like healthy foods. There's such a need for organizations like mine to be able to weigh in on these things and help educate the public. And it's going to have such a big impact on the health of that community. Susan, you mentioned cost as a catalyst for you. Can you share a little more of your personal and professional experience on the costs of healthcare?
Well, one thing that stands out is actually a personal story. I looked into buying health insurance on the health exchange in Kentucky. And for a silver plan, there were only 2 insurance carriers that were offering individual plans. And the monthly premiums, deductible, and out-of-pocket maximum amounts, which you can see on the screen, mean that if either my husband or I needs expensive medication or some type of expensive treatment, that we will wind up spending over $35,000 a year, potentially every year, in order to have health insurance. And that's simply unaffordable. Another example is if you consider a family of 4 earning $100,000, where the parents are earning $100,000 per year, which means they don't qualify for any subsidies, they could, depending on the age of the parents, have only $40,000 left to live on a year after they've paid their health insurance premiums. And that would leave them only around $22,000 after rent. That doesn't leave much for car payments, car insurance, food, clothing, water, and electricity, not to mention cell phone bills. In fact, the average health insurance expenditure per month is the same as the average rent or mortgage payments, which is around $1,500 a month.
Wow, that's just such an amazing impact on folks' paychecks. And you know, you talk about the cost of insurance. The cost of medication is tremendous. I've read stories that talk about patients, heartbreaking stories where patients can no longer afford their insulin.
You're absolutely right, Jeff. This is incredibly distressing and it affects a lot of people. In fact, 8 to 15% of people go without medications, necessary medications, because of cost. As a gynecologist, I actually saw this all the time. One fairly common example was an antibiotic called doxycycline, which is used commonly to treat a sexually transmitted disease called chlamydia and its sequelae known as pelvic inflammatory disease, where infection gets into the uterus, tubes, and ovaries and can be a life-threatening situation, commonly found in association with either chlamydia or gonorrhea, sometimes not either one. And what would typically happen is that I would send an electronic prescription through to the pharmacy, and sometimes later that day, but sometimes not for another day or two, my office would get a call back from the pharmacy saying, I'm sorry, that medication is not covered by the patient's insurance, or it's not on their formulary. And then I would have to call the insurance company, try to get a hold of the pharmacy benefit manager, and then argue with them about why the patient needed the medication. And in some cases, I would actually photocopy a page of the recommendation for the Centers for Disease Control's recommended treatment for chlamydia or pelvic inflammatory disease in order to prove that what I was trying to do for the patient was the correct thing, which after 30 years I shouldn't need to do. Ultimately, the medication would get approved, but not only did it take a tremendous amount of my time and my staff's time, but even more importantly, it typically resulted in a delay of care for the patient, and that is simply unacceptable. Pharmaceutical companies do invest heavily in research and development. They also have all sorts of tricks to keep their prices high. In another example, they decreased the dosage of a particular estrogen tablet. This had no clinical benefit to the patients. It did not make the prescription safer, easier to use, or more effective. However, the original dose was nearing the end of its patent protection, so they were able to get a new patent for this lower dose, i.e. charge more for it, and they took the older dose off the market. The net effect was to keep the price high, depriving many women of access to this quality of life medication. I should mention that at one point when I priced this medication, it was as much as $700 a month. And currently, a 1-month supply is a little over $200, which is still astronomical. And these shenanigans happen over and over again every day.
Wow, and Susan, as you mentioned those things, all of those are legal. So what this results in is people are making tough decisions. 1 in 4 or even 1 in every 2 people are now skipping care because the costs are just too great. In another study that looked at 60,000 people and their choices to buy medication or other things, 2 out of 3 chose food over buying medication because they just couldn't afford to do both. It's really astounding. And when you think about it, maybe it's yourself, maybe it's your extended family or your neighbor. Likely someone is having to make this tough choice. And we just don't need to be in that position. So, Susan, what can we do as individuals to help address the costs in the healthcare system?
I am glad you asked me that question. Healthcare policy decisions are made at the legislative and governmental levels. For example, there is currently a bill in Congress which focuses on high drug costs, known as the Elijah E. Cummings Lower Drug Costs Now Act, H.R. 3. This bill allows the government to set the maximum amount which can be charged for a drug at 120% of the average price of the medication in 6 comparable high-income countries. It can also mandate that the price be set at the lowest price for which it sells in any of these countries. This wouldn't immediately reduce prices on all medications. The bill actually requires selecting 50 medications to start with and can go up to 125 medications. It passed the U.S. House of Representatives in December of 2019, primarily along partisan lines, and is currently waiting on additional action in the U.S. Senate. With all of the focus on the stimulus bill for COVID-19, its prospects are not clear right now. One specific thing that you can do is contact your U.S. Senator, and by your, I mean all the viewers out there, and encourage them to vote in favor of H.R. 3. More generally, make sure that you know the healthcare policy positions of your candidates for office and elected officials. You can find out this information on their websites, and we have that information for you on the screen. Call and write them, and really, really importantly, vote. Your vote matters, and it will make a difference on what happens in healthcare in the United States.
Wow, 2 really important things there. Even during the pandemic, care for other conditions can't stop. We need to make sure that folks can stay healthy. And 2, we don't always think about this every day, but drug costs are different here in the US than they are in other countries. And we can use that as an example to learn from. So we really have an opportunity in this country to think about healthcare differently. Better health and lower costs are both possible. As I just mentioned, we can learn from other countries. We can also learn from parts of our own country that are really doing it well. So join us again as we talk about social determinants of health next time. Social determinants of health have a big impact in the quality of our lives and can also influence costs. So we look forward to talking with you again in the future. Susan, thank you very much for your time today. It was a pleasure to connect.
Jeff, it was a pleasure talking with you as always. Look forward to next time.